Next joint that we're moving to is the hand and wrist. This can be a very complex joint due to the small anatomy and multiple nerve supplies in the area. So key to this exam is often reviewing your anatomy and making sure you not only understand the bony anatomy, but you also understand your nerve supplies and different areas for where tendon insertions lie. That being said, we're going to start with our wrist exam just like we do with most other joints with inspection. Typically things that are important to look for with the hand and wrist are not only areas of trauma, swelling, or deformity, but also areas of atrophy. As you can often see on somebody's hand, areas where a nerve may be being injured that shows changes to the muscle or other parts of the hand and wrist. After inspection, palpation is often key and will lead you to narrowing your diagnosis. Key areas that you want to palpate for are any areas of pain, letting pain be your guide to focalize where you're going to do your exam. Otherwise, you want to maybe palpate for common things such as a trigger finger. So this is often done on the palmar aspect. You might notice an area of catching when they're moving their finger through flexion and extension, or just palpating along a joint to see if there's any instability or problems at any of the wrist or finger joints. After we do the palpation, I like to have them go through range of motion, often starting at the wrist. So typically I'll have the patient then take their wrist and go up into flexion, and then they're going to go into extension. Following extension, I then like to bring them back to neutral and then have them go into ulnar deviation and then radial deviation, making sure I don't see any deficits there. If they've been tested there, I then like to test the individual joints of the finger, often making sure that they can make a full and complete composite fist where they can grip it all the way down. If you see an area that's lacking with flexion, then you often want to test the independent joints after that. We'll bring them back into full extension after this just to make sure that they can achieve that. Once again, if you notice an area that is lacking full extension, you want to test that further. Following their active range of motion, you may passively take them through different ranges of motion based on where their pain and symptoms may be, such as at the wrist, or if you're localizing it down to a finger, you may actually run through their PIP or DIP joints and making sure that they can achieve that range of motion. Following our range of motion testing, I then like to test strength. So the first thing I do is test their wrist flexion, where you're going to make sure that there's no neurologic weakness or deficits. Then I'd move them into extension, making sure that they don't have any weakness there. If you notice any changes, you can test strength in ulnar deviation or radial deviation as well. But this is not something that is always done. Often when you're testing finger strength, this might even be tied into your neurologic exam, but typically you want to test their finger flexion so you can pull up against their DIPs. You can take their thumb and often test extension here. You can test individual extension at each finger, making sure that they can achieve that. Other important areas would be testing abduction, so spreading of the fingers, or adduction, where you might put a piece of paper between their fingers to make sure that they can grip that or hold that. Following that, we then move into a multitude of specialized tests. It's often best to break down the specialized tests based on the area of the wrist or the hand that you are concerned about. We're going to cover just some very basic ones today, but be sure to review any videos online that maybe offer further insight into these tests. The area that I like to start with, if they're having radial-sided pain, would often be thinking about areas such as CMC arthritis. A good specialized test for this area is called the grind test, where you're going to grip their thumb down at the CMC joint with your proximal hand. With your distal hand, you're going to then grip up onto their metacarpal bone, and then you're simply applying axial load down the bone and going in a circular motion to really grind that joint. If this elicits pain, discomfort, clicking, that can often lead you to a diagnosis of arthritis. This same test and concept can be applied to almost any joint further up the finger, so be sure to localize their pain and symptoms, and then you can use that test in other areas. Another common area of radial-sided wrist pain can be into your extensor tendons. So when you're talking about the different compartments, that's an important area to review. But a very common test is called Finkelstein's test, which tests for tenosynovitis or inflammation along the tendon sheath. Often with this test, you're going to have the patient put their thumb inside a full composite fist and then have them ulnar deviate their wrist in this direction to put traction on those tendons. A positive test would often lead to a diagnosis of de Quervain's tenosynovitis. Moving to the more medial aspect of the wrist in between the radial and ulnar joint, oftentimes patients can have chronic wrist pain related to distal radial ulnar joint instability or DRUJ instability. So a good test for this area of the wrist is actually testing for that instability, and it's called the piano key sign. So often you can either press down on your ulna to see if that has more motion than it should or compared to their other side, or you can even grip both sides and then wiggle the radius and the ulna between your thumb and index finger and then compare that motion to the other side. Moving over to the ulnar side of the wrist, a very complex structure but can also be a source of pain is your TFCC complex. This area is very important to test for mainly with palpation, but there are also a multitude of specialized tests that we will not cover here. But anytime you have ulnar-sided wrist pain, you always want to be thinking about that complex. Finally, the area that's much more common for other injuries and sources of pain would be looking at testing for median nerve compression. So typically when you're kind of working in this area, you're going to be ruling out carpal tunnel syndrome. Often what you're going to start with is a history and physical exam that seems to match carpal tunnel syndrome, but in addition to that, two helpful tests that can be done are Tinel's test, which is where you use your index finger to tap along the path of the nerve as it goes through the carpal tunnel. Recreation of numbness, tingling into the first 3.5 digits will often indicate a positive test. The other test that can be done here is a Durkin's test, where you apply compression to the median nerve with your index finger and then fold the patient into full flexion. They will often start to have a recreation of their numbness and tingling in those same 3.5 digits. The other way that this can be done is Phelan's test, where the patient will do it themselves, putting the back of their wrists together to then put the compression along the median nerve.